2, 1. We are live now. Good to go.
A very good evening to all the participants. I welcome you all to this third episode of Masterclass series, As Blues. The series is As Blues, and today we are back with yet another interesting and breakthrough topic. Today's topic is genitopelvic penetration disorder, and I am sure the faculties and chief guest will justify this topic, and I welcome all the faculties and chief guests to this session. This is a combined initiative from Foxy Sexual Medicine Committee and INTAS. So thank you so much, Foxy, for this wonderful initiative, and we are really privileged to be a part of this. And today's moderators will be Dr. Neeraj Jadhav, who is a chairperson of Foxy Sexual Medicine Committee, and Dr. Apurva, who is in public relation in charge with Foxy Sexual Medicine Committee. So without taking much time, I will hand over this session to the moderator. Please take the charge, Dr. Neeraj.
Thank you, Lai. Good evening, friends. Welcome all to this third session of Masterclass series on S Blue, sexuality and sexual health. Let's begin with a prayer to Almighty God to keep all of us safe in this COVID time. We are overwhelmed by the feedback of our previous two sessions. In both the previous sessions, we had more than 1,500 delegates attended. Sexual Medicine Committee Foxy is always trying to spread the knowledge of sexual health among our gynec friends. More and more people are wanting to learn about sexual medicine. That is the greatest satisfaction for me as a chairperson of Sexual Medicine Committee. Today, we are going to discuss one very important topic, that is GPPPD, that's genitopelvic pain or penetration disorder. Genitopelvic pain or penetration disorder refer to significant pain and difficulty with penetrative vaginal sex that lasts for at least 6 months. GPPPD is actually an umbrella term for two sexual pain disorders, that is dyspareunia and vaginismus. The term genitopelvic pain or penetration disorder was developed in 2013 when the categories of dyspareunia and vaginismus were combined for the diagnostic and statistical manual of mental disorder of the 5th edition. Friends, today we have one renowned guest with us to bless us for this session. He doesn't need any introduction. He is symbol of how a teacher should be. Yes, I am talking about a great academician and a past president of Foxy, Dr. Pankaj Desai, sir. He is a lifetime teacher and his class is all universe. Anytime you call him and he is ready to assist you or help you. We welcome you too, sir. Please bless us with your words of encouragement. Pankaj Desai, sir, please.
Honorable Dr. Neeraj Jadhav, the chairman of Sexual Medicine Committee of Foxy, Dr. Apurva Kumar Datta, who is another functionary of that committee, brilliant faculties. I have been knowing them for many years now. Dr. Shantanu Abhyankar, Dr. Sunil Jindal, Dr. Jaya Rani. I would like to, in the 5 minutes which I have kept to myself, I am going to tell you 2 stories. They are true stories. I always love to tell stories. Kahani sunata hu main. But before that, I would like to congratulate Neeraj, Dr. Neeraj. The reason is, this is not a formal congratulations. At the end of the stories, you will realize why I am congratulating him. My OPDs, with God's grace and Neeraj knows, used to be very busy. And one couple, and this used to happen often, one couple walked in. We had an enclosure separate for the consultant. And one couple walked in, and always, after writing the history, the junior resident would accompany them, whosoever is to be shown to me. She sat by the side, and this couple sat in front of me. And they started explaining their sexual problems explicitly, without any embarrassment. And I was really very happy they came out openly what was happening to them. And that was the time I always loved to be aware. I could see a smile on the face every time some explicit sexual problem or sexual matter was discussed. On the face of the girl, there used to be a smile. I handled them, whatever had to be done, which Dr. Sunil and all, Shantanu and all are going to discuss. And then they left. That was the time when this girl was also going. I said, beta, you just wait. I made her sit next to me. Not firing. No. I told her that, beta, when you are able to discuss osteoarthrosis and renal failure as dispassionately and clinically as any sexual problem, then and then only you are fit to handle these cases.
Correct.
The fault was not hers. The fault was that of the society. And when I'm society, I'm not telling the entire Indian society. The Society of Teachers of Obstetricians. Because we don't teach and we are not taught sexuality dispassionately. This is very important. This is what exactly Neeraj has done. I don't know for how many years sexual medicine committee is on. I really don't know. He might be third or fourth chairman. But how many times you all have seen this type of activity? And seemingly unglamorous committee. There is no there is no big money involved, big technology involved, nothing. And the way he has turned it to the good of members of Foxy, that is where he will bring in that dispassion. And therefore, when I started and said congratulations, this is the reason I said congratulations. After a few months, a girl, an unmarried primary gravida, was brought to my chamber again, my enclosure. Neeraj knows where we consultants used to sit. And that same girl came with her and said, sir, you please examine her and talk with her. There were already 2 assistant professors in my unit. An unmarried primary is not something which requires the professor to go and see. But still, I could make out from the sense of that girl that there is something. I did whatever I had to do. And then when the patient was going out, that girl herself turned and said, sir, I did not take her to so and so. No name given. You may not know him also. But sir, his handling of such cases is very undignified. See, this is where the difference was. How dispassionate that girl became when the teacher just explained to her. And she said that he is asking all titillating questions. And that I feel very embarrassed, sir. And therefore, I brought her to you. So this is why I congratulate Neeraj, the entire committee. And I also congratulate Shantanu, Sunil, Jayarani and all other who might be the faculties in past and in future for taking interest in this matter. Not only just because a lecture is given, you go and give lectures. Come to me. I have, tomorrow again I have one. I have so many, I will be more than happy to hand over a webinar to you. They have come with a passion. They have come with a commitment. And I congratulate all those involved, including the faculties, for taking up this topic, very much necessary, and conveying the message of dispassion and pure science to everybody. May God bless you all, and I wish all this webinar a great success. Thank you very much.
Thank you very much, sir, for your kind words. Now I invite my co-moderator, Dr. Apurva, who is the National Coordinator for Public Awareness for our Sexual Medicine Committee, to introduce our three masters for today's session. So, Apurva, please introduce our three
Thank you.
masters.
Thank you so much, Neeraj sir. And thank you so much for your kind word, Pankaj sir, and to bless us with your blessings. So without wasting the time, in a very short, I just introduced faculty for today. We don't need any introduction. Each and everyone is great in their field. Thank you for coming and giving your precious time for this master series. First, I would like to introduce and welcome Jairani Kamraj ma'am. Thank you so much for coming. Ma'am is Director, Akash Fertility Center and Hospital. Next faculty, Dr. Sunil Jindal sir. Sir is Chief Consultant, Laparoscopic Surgeon, Andrologist and Reproductive Medicine Specialist at Jindal Hospital. Next, Dr. Santanu Abhyankar sir. Sir is the past chairperson, Sexual Medicine Committee, FOXY. So thank you and welcome to you all for this web series. So without wasting the time, we are starting our scientific session. First, we all know today the topic for the discussion is, we are already discussed about it, that is the genitopelvic penetration disorder. So first question to you, Santanu sir, actually what do you mean by this topic? What is the etiology? What is the pathophysiology and epidemiology? Santanu sir, over to you.
Thank you, everybody. Can you see my screen?
Yes, sir. It's visible as well as audible, sir. Yes,
right. Thank you. So, in the brief time that I've been given, I'll go over the pathophysiology, the etiology, the etiopathology of genitopelvic pain and penetration disorders. At the outset, I thank Dr. Neeraj Jadhav sir, as well as Dr. Apurva and the whole team for involving me in this particular webinar. And thank you, Dr. Pankaj Desai sir, also for being here. Your encouragement always means a lot to all of us here. I'll talk about the etiology, and the causes of sexual pain, as you all know, are manifold. And so many times we may not be able to pick up a particular cause. The causes could be because of some superficial lesions, or they could be causes related to some pelvic tissues and pelvic organs. The superficial causes could be enlisted as due to atrophy, vulvitis, vulvovaginitis, interstitial cystitis-like syndrome, condylomatas, dermatological disorders, non-infectious inflammations, epithelial defects, scarring. The size of the penis at times can be problematic, urethritis, anatomical variations due to Mullerian tract anomalies such as phimosis of the cervix, that is the horizontal membrane that is present in the vagina. Hymenal remnants can be painful. Episiotomy neuromas can be painful. Radiation can cause problems. And sometimes physiological, like the novelty of the act itself for the first few attempts at intercourse can be very, very painful. So also lactating women, because of high levels of prolactin, they develop dryness of the vaginal mucosa, and this can cause pain. Postmenopausally, the pain may be due to estrogen deficiency, age-related vaginitis, or the deep pain may be related to chronic PID, a fibroid uterus, the particular position of the uterus, an ovarian mass, a foreshortened vagina, which can result from a vaginal hysterectomy and correction, and a rather overcorrection of the prolapse of the rectovaginal prolapse. Vaginal septum I have already mentioned, and hemorrhoids, fixed inverted uterus can be a cause of pain, ovarian remnant syndrome can be a cause of pain, and irritable bowel syndrome and such other bowel and abdominal pathologies can also give rise to dyspareunia. Prevalence, it varies according to how you measure it, where you are measuring it, and how open your patients are. So any figure between 6 to 27%, various studies they have been reported. And this is for continuous dyspareunia. A sporadic dyspareunia, the incidence could be almost 4 times more. The classification of such disorders is actually a great problem. And moreover, disorders of sexual pain, they do not actually fit into any phase of that particular sexual response cycle that has been classically described by Masters and Johnson's, and of course, presently modified. In fact, the assumption that vaginismus and dyspareunia are two distinct entities, that has been challenged, and our chairperson, Dr. Neeraj Jadhav, in his introductory remarks, has already enlightened us about it. Regardless, we shall talk about what exactly both these things mean. Both seem to have following 3 components necessarily into them. So vaginismus and dyspareunia, that is pain and penetration disorders together, they have at least 3 components. One is the problem of muscle tension, voluntary or involuntary. It could be voluntary or involuntary. It is important to understand that it could be involuntary because usually it is the woman who is blamed for this particular problem, and doctors do it. I have seen consultants doing it, but please, we should be aware that we should not be blaming the victim and assume that the woman is the victim unless otherwise proved, unless you have reasonable evidence to show that it is being done on purpose, which is of course a possibility. But usually it is an involuntary spasm of the pelvic muscles. It is limited to the vaginal muscles, or it can extend to the whole of the pelvic floor, at times involving the adductor muscles, the back, and even the jaw. Fear of sexual pain associated with genital touching or coitus, or fear of intercourse for reasons other than pain, because the girl feels that it's a taboo to have sexual intercourse, it is unreligious, it's sinful, and so many other things are there. So the fear may be due to pain, or it may be regardless of the pain, but the lack of penetration, lack of intermission, lack of consummation of marriage is how the couple possibly presents. Sometimes they even present with a complaint of infertility, and then you're surprised that they've been married for so many years, but still the marriage is not consummated for reasons such as vaginismus or dyspareunia. And there's a tendency towards avoidance of the act of sex. Now, vaginismus has been defined as an involuntary spasm of the pubococcygeus muscle, because the external muscles external to the pelvic diaphragm are very, very weak. It is the pubococcygeus muscle which is the problematic muscle. Now, it is important to understand that this, because just as you teach Kegel's exercise for so many other conditions, teaching Kegel's exercise also aids in teaching the patient to relax these muscles when they are expected to relax. So it is important to understand that vaginismus involves the spasm of the pubococcygeus muscle. In fact, even insertion of any finger or any object such as a speculum becomes very, very difficult. The International Committee has recently recommended the following definition. I just read it out for you. The persistent or recurrent difficulties of a woman to allow vaginal entry of the penis, a finger, or any other object, despite the woman's expressed wish to do so. So she's willing, wanting it, but cannot do it. There is a variable avoidance. So there is a variable phobia, involuntary pelvic muscle contraction, and anticipation or fear of the experience of pain. And structural other physical anomalies should be ruled out before you address this particular problem and label it as vaginismus alone. This results in difficult and often impossible penetration, and the pain and burning at the introitus and dyspareunia with forced intromission is being reported by the couple. Commonly, even a visual physical examination is refused. Even separation of the labia to inspect the introitus is refused. Now, dyspareunia is defined as recurrent or persistent genital pain associated with sexual intercourse. And this can be subdivided into deep and superficial. We've already gone over some of the causes of dyspareunia. And it could be with or without what is called as the vulvar vestibulitis syndrome. Now, this includes painful penile vaginal intercourse or pain upon touching the vulvar vestibule, and signs limited to variable vestibular erythema. Apart from that, you have nothing. So the patient just complains of external genital pain and tenderness. Sometimes these patients say that they can't even sit, and you just can't find a cause as to why this is happening. The pathophysiology, there are so many papers and so many theories explaining the pathophysiology, but I'll go over them in briefly and just highlight the important points. Now the pelvic floor, the entire pelvic floor is now thought to be having an integrated functional structure with varied disorders of micturition, defecation, sexual and genital pain. So all of them should be given a thought together. Many a times, disorders of micturition and defecation are associated with sexual and genital pain, but we don't explore them enough, don't ask enough questions to bring out these particular issues. There's now evidence to show that the pelvic floor, like some other muscle groups, are indirectly innervated by the limbic system. The limbic system, which is the first system that evolved in our reptile ancestors. So it is innervated by the limbic system, and therefore it is highly responsive to emotional stimuli and stress. How this happens? Just look at this. Now the pelvis is innervated by the autonomic as well as somatic, that is sensory motor nerves. And odd as it may appear, it is now known that the efferent sensory nerves of the pelvis carry efferent signals as well. So not only do they carry impulses towards the brain, that is orthodromic, but they also carry signals to the periphery, and that is antidromic direction. And the antidromic impulses, they produce vasodilatation, edema, hyperalgesia in the area of the innervation, and this is called neurogenic inflammation. This is called neurogenic inflammation. So as the signals are ascending up, they are also sending signals of inflammation towards the area in which the signals are coming from. So this is the neurogenic inflammation. That is one of the causes that explains why the act, which otherwise should have been pleasurable, becomes suddenly painful and pathologically painful. This is a maladaptive response. Otherwise, it helps. Small amount of erythema and pain is in fact enjoyable, but when this is a maladaptation and it becomes pathological. Now, neuropathic pain is typically characterized by spontaneous paresthesias, dysesthesias, and evoked pain. And the pain is experienced when impulses in the brain via A delta or C fiber, nociceptive afferent fiber. So any pain fiber that is carrying pain impulse will cause reflex inflammatory response in the genital organs, and this causes pain. Minor tissue injuries can cause reduction in the threshold for nociceptors, resulting in what is called as peripheral sensitization. So the stretching, the pain, and even trauma that ought to have been enjoyable because of peripheral sensitization now becomes pathological, and this becomes the pathognomonic sign of dyspareunia. This is how the cycle begins. And this leads to responses to weak non-axial stimuli, that is allodynia, and further stimulation will lead to exaggerated pain response, which is technically called primary hyperalgesia. So that is what happens in the brain's muscles and nerves when a woman is complaining of this. There is another phenomenon. Allodynia can also occur due to abnormal signal amplification in the central nervous system. So once the signals reach the brain, a small signal is amplified so many times. This is called central sensitization as opposed to peripheral sensitization, which I just explained a few minutes ago. Now here the signals entering the CNS through non-nociceptive A-beta touch fibers, they evoke pain. So they actually are not the pain fibers, they ought to have been the touch fibers, but there is an exaggerated response to this particular nervous circuit as well. Now, this also explains why therapies with tricyclic antidepressant, venlafaxine, carbamazepine, gabapentin, they help in many cases, and this is the explanation. A lot of people have studied individual psychological and personality characteristics in women with vaginismus and also in women with dyspareunia. And there's a slight difference between the two, but it is enough for us to understand that those with vaginismus, they have been noted to have higher rates of comorbid anxiety disorders such as agoraphobia, going in public places, and without phobic disorders, obsessive compulsive disorders. Personality traits, they suggest that presence of self-focused attention and negative self-evaluation. Whereas women with dyspareunia or vestibulitis, what they have in common, they have been noted to have increased anxiety and depressive disorders. Also, there is an attention bias, what is called as an attention bias, where the person becomes hypervigilant of pain and any stimuli that can possibly cause pain. Now, we've seen about the brain, the muscles, the spine, and so many other things. But even mucous membranes are involved in these sexual pain disorders. And acute inflammation of the vulvovaginal mucous membrane, it is a common cause for dyspareunia. Now, often the cause is very readily discernible, such as candidiasis, trichomoniasis. We are all familiar with these infections. But there is chronic vulvovaginal pain, and it is difficult to pinpoint the cause. I know of a case who got better following antihelminthic treatment, mebendazole. That worked in that particular patient. So, and I'm sure that each of you has a story to narrate regarding this. So the patients have a very bizarre presentation, and there is a paucity of physical findings. The history is very, very vague, and it really becomes a challenge to treat these patients and to manage and explain what exactly is the problem. There are certain problems that are known, explained, studied, and we have good documentation of these things, such as chronic vulvar dermatosis that are causing problems, such as lichen simplex or lichen sclerosis, which in the form of chlorosis vulvae is something that we are all familiar with. Lichen planus, it gives rise to superficial ulcers with concomitant inflammation of the vaginal mucosa. And one must always ask if this is cyclic, because if it is cyclic and related to menstrual cycle, you will find that these patients will also give history of inflammation and other mucocutaneous junctions, such as stomatitis or sometimes conjunctivitis that happens at around the time of menstruation. All of this fits into what is called as Behçet syndrome, and topical steroids for prolonged period and sometimes interleukin inhibitors, anti-inflammatory agents are key to the management. As far as lichen sclerosis or chlorosis is concerned, all of us have seen these patients, and long-term steroid, topical steroids, or very rarely oral steroids is the treatment of choice. The lichen simplex is again caused by causes severe sexual pain, and it is a result of the itch cycle due to chronic scratching, and topical steroids and antihistaminics happen to be the line of management. Vulvar vestibular syndrome is an entity that has been classified as defined by a triad of vulval itching, burning, and pain with sexual activity, and even otherwise. So even sitting, running, or using a sanitary napkin, using underclothes can become a problem for these patients. Vulvodynias, as the name suggests, are intense, painful conditions wherein the vulva becomes painful, causing profound sexual and psychological distress. And it usually this is the presenting symptoms. And there are no positive findings, like I said before. And the treatment could be topical treatment or oral tricyclic antidepressants or anticonvulsants. And why they're helpful, we've already seen in some of the references that I made to the pathophysiology before this. With this, I conclude a brief overview of the pathophysiology of these particular disorders. And I end my presentation by thanking Dr. Neeraj et al. Once again. Thank you.
Thank you, Dr. Kantala. Can you just tell us about why this new terminology came into act? What was the problem with two different terminology like vaginismus and dyspareunia? Why this new terminology?
Actually, the pathophysiology and the presenting symptomatology and more or less the management don't really change much. And therefore, rather than labeling them separately, because any classification that is not going to help you improve your clinical output is probably meaningless and only theoretical. So that is why they have actually combined the two things together, because the line of management, the protocols for investigations, more or less, they remain the same.
Thank you. Thank you. So now I invite Dr. Jayarani Kamaraj, our next speaker, to tell us about the evaluation, history taking, examination, investigation, and differential diagnosis in GPPPD. So welcome, Dr. Jayarani. Please.
Good evening. Vanakkam. Greetings from Chennai. And a very special thanks to Neeraj for making me a part of this wonderful program, this master's classes. And very special thanks to the chief guest, Dr. Pankaj, and also all the dignitaries and the faculties here. So genitopelvic pain penetration disorder has rightly talked a lot about its causes, etiology, how it is different from other pains is well talked by the previous speaker. But sex shouldn't be painful. That's what we are all working for. So how we can remove this pain? That is an ultimatum for any consultant who practices sex. But if you look into the data, 3 out of 4 women will experience some sort of pain all through their lifetime. That is a very, very interesting fact. So this painful sex, what we call as a dyspareunia, definitely have a major impact in the quality of the women's life. So pain, we all know it is a part of everyone's life. When there is a tissue injury, there is a natural response is the pain, and that result in an adaptive change in the behavior and the cognition for the affected person, as well as the people who are with that, and all the people who are surrounding also have a change. But when the injury heals and the pain fades off, but for some conditions, this pain persists. When it persists without fading, that definitely have a profound effect on the person's life. And in genital pain or the sexual pain, it has a great impact on the act sex. And that definitely have a negative impact in the couple's life, leading on to a very great impact on their sexual health, psychological health, relationships, and also the quality of the life. So a chronic genital pain definitely have a greatest impact in every part of the couple's life, especially the women. So this is why it is very important, as rightly talked by the previous speakers, that the prevalence is very high, ranging up to 16 to 24%. No specific data for that, but still they have found out nearly 1/3 of the women being affected by this condition. But very interestingly, as rightly talked about the speaker, that there is a relative lack of knowledge about this condition among the practitioners. Many a times the women come with a pain, and most of us may not know exactly what is the reason, because this is a reason that coming from the brain, from the central nervous system, from the neurological, from the psychological, everything plays a role, and there is no obvious observable reason for the pain. So automatically the healthcare providers will always treat them as a psychological cause, stating that must be because of a sexual abuse or because of a sexual trauma, and making the women come again and again with the same complaint, not getting relieved of this. So a very important thing about a comprehensive understanding of this condition is very mandatory. So there comes our etiopathogenesis, as rightly talked by the previous speaker, that he has talked about what causes this, how it is really important, where is the primary source, the pineal gland, which is a very sensitive area for the emotions, stress, anxiety, all these things plays a very important role. So a knowledge is very important about this condition, mainly to differentiate among different types of genital pain. You can't treat, you know about all the types of pain, where it comes, it may be a superficial, or it could be a deep, or it could be even a different variety, or it could be a different cause. That is understanding the different. So it is very important to outline the step for a thorough medical and psychosexual assessment for treating this women with this problem. Thereby you can give them a proper awareness, and that will give us a proper awareness of evidence-based treatment options. So we all know this genitopelvic pain and penetration disorder, that is GPPPD, which is a sexual pain disorder, which was previously referred as a sexual pain disorder. Now it includes both the dyspareunia, which is a pain in the pelvic area during or after intercourse, or a vaginismus, which is an involuntary spasm of the musculature around the vagina, resulting in a penetration being difficult, painful, and impossible. Many a times we have a confusion whether how to distinguish between vaginismus from dyspareunia. Very simply, vaginismus per se will not hurt. But whereas a dyspareunia, the women will have a continuous pain. She may have pain even before intercourse, or at the time of intercourse, or even after the intercourse. But vaginismus, very classically, it will be present only when there is an attempted penetration which could be either a penile penetration or even a pelvic examination by the fingers or even an insertion of the tampons. So in this way, you have to differentiate between the vaginismus and the dyspareunia mainly by these factors. But many a times we have always an overlap of these symptoms, because some researchers says that the dyspareunia, the vaginismus, it's impossible to differentiate because the vaginal penetration problems are not only specific to vaginismus, but also it is a symptom of dyspareunia. In particular, when there is a provoked vestibulodynia, which can be consistently implicated as the cause for vaginismus or complicating the treatment. Conversely, the pelvic floor pathology interfering the vaginal penetration has been reported as a key symptom in virtually all women with vulvovaginal pain. So that is the reason sometimes we receive clinical reference for a woman with vulvar pain as a vaginismus or a partial vaginismus, which always they overlap. So it is a clinician's point to identify whether it is a vaginismus or it is a dyspareunia due to some other reasons, that the real reasons is the vestibular pain, which needs to be properly understood. So in this step, we have to classify what are all the types of sexual pain, and this will give us an idea how we can go about the diagnosis, differentiating other reasons, and planning the treatment for the patient. So the types of sexual pain, we all know it's an introital pain where there is a pain on initial, just starting the penetration. Usually, commonly, it is because of the poor arousal, which may be causing a mild vaginismus. Any perineal surgery, like your episiotomy or any surgery in the pelvis, a bathroom abscess, drainage scar, all these things will have a pain, especially because of the pudendal nerve entrapment, which is very important factor for this introital pain. They will have a pain just on the penetration, then they will be fine. And second is the levator anemyalgia, which is a mild vaginal pain. They will always have pain after intercourse. During the orgasm, they will have a pain. So it is mainly due to the levator anemyalgia, which is a very classical pain they will have after or during the orgasm. And third is a deep vaginal pain, which is commonly due to an endometriosis or a pelvic inflammatory disease or due to any radiotherapy or the pelvic radiotherapy, which can be the cause for this. And the pain before intercourse, that is a very classical pain. There is a vulvodynia and also a phobic attitude towards the penetration. They will have a phobia. So they may develop just before the intercourse itself, they will have a pain. During intercourse, it is because of all this mechanism which may cause a contraction of the pubococcygeus muscle and the pelvic muscles, which will lead on to the pain during intercourse. And as rightly said, that the mucosal damage by an infection or even by a lubrication or by a repeated washing or by a contact with an irritants or a deodorants, all will cause a pain after intercourse. So these are all the pain that you should keep in mind. And very interestingly, this vulvodynia has to be a proper idea, and the definition is very important, because the latest DSM-5 classification states that it's a category of sexual dysfunction, which they include difficulties with vaginal penetration during intercourse, marked vulvovaginal pain or the pelvic pain, or a fear or anxiety about the pain, and there should be always a tensing and tightening of the pelvic floor muscles during attempted penetration. So that is why we include the dyspareunia and the vaginismus together in this genitopelvic pain penetration disorder. It could be a lifeline or a lifelong or acquired. Depending on the severity, we classify as a mild, moderate, and severe. And usually it should be, the patient should have a symptoms for at least 6 months. Then only you have to classify this as the DSM-5 disorder or the GPPD disorder. So how are you going to distinguish between these different categories of vulvodynia? So there are very many established causes of the genital pain. We know it could be because of some infection, some inflammation, or it could be an allergy, many of the etiology. But this vulvodynia, characteristically, it is a pain which cannot be explained by such descriptions. And the classification given by the International Society of the Vulvovaginal Disease classify this as a vulvar discomfort, most often described as a burning pain, occurring in the absence of relevant visible findings or a specific clinically identifiable neurological disorders. That is a very important diagnostic criteria to state that it is a vulvodynia. That is very important. It's an umbrella term. It could be, there are a lot of subtypes according to the location. If it is a localized, we call them as a localized vulvodynia. If it is generalized, we call it as a generalized dynia. Localized means it could be in the clitoris or in the vaginal entrance in the vestibule. We call it as a vestibular vulvodynitis. And a generalized vulvodynia, it can be still more specifically, we can say how it has been provoked, whether it could be provoked or unprovoked or mixed. So we should know about what are the types depending on the process. Depending on the types of vulvodynia, we classify them as provoked vulvodynia, which is characterized by localized provoked pain. Usually the prevalence is around 12%. Most commonly, they present with a severe burning, stabbing, and a sharp pain upon the contact of the vaginal opening. The common situations involve the vaginal penetration during the sexual activity. There some women also have experienced pain during such activities, ever as a primary, always they will have. And some people initially they would have been free and later on they would have developed the pain. We call them as a secondary PVD. So generalized, it is characterized by the generalized unprovoked pain. It's roughly estimated to be in a prevalence of 5 to 6%. Women suffering from GVD typically report a fairly constant burning, itching pain in the large region of whole external genitals. Since it is characterized by an unprovoked pain, it can occur at any time during the activities and usually occur out of the blue, and that can be exacerbated even by any contact, even with your dress, with your any touch, it will cause a pain. A mixed pain, it is a low-grade itching pain they will have. They may say that it is something that gets worse if they sit for a long time or even an attempted intercourse, and sometimes some friction itself may cause this type of a pain. So it is a subset of the vulvodynia where the provoked pain of PV, in between this provoked pain and an unprovoked GVD. So when a woman presents with this type of a pain, how you're going to approach her? Is the pain really sexual? It is very interesting to note that this patient present with pain during intercourse activity, definitely all will think of it as a sexual problem. But you should keep in mind, this need not be a sexual problem. It is something very unique that to say diagnosis dyspareunia, but how you are going to differentiate? Because sometimes this pain problem, which is defined by the situation with which it interferes, that's the sex, rather than the location and the characteristics of the pain. So there is always a lot of discussions, and there is a less research has been done when you just simply diagnose as dyspareunia. Many a times we miss the basic cause. Simply to state that when you have a pain in the jaw, you cannot eat. So you reduce your intake, you become very thin, and you think it's an eating problem. No, it's not eating problem. It is the problem with the jaw that makes you make not to eat. The same way, the dyspareunia, it is not a problem of sex or sexual dysfunction. It is something because of the inability to do sex, they land up with a problem of a pain. So because of the pain, they don't do sex. So it should not be confused with a sexual dysfunction or a sexual problem. It is the pain that is a problem which prevents these women to do sex. That's a very important one. So it is a pain condition. So when you have a patient, you have to differentiate whether it's a sexual dysfunction or it's a pain condition. So that is a very classically, they will say if the pain, they will come as a pain. If they have a difficulty in sex, doctor, I cannot do sex. But the pain, they will say, I have a pain even before intercourse. When I touch that place, so that will give you a clinching diagnosis of what is a type of pain and how you're going to evaluate her. So if it is a pain condition, you should concentrate on a focus questions on pain, whether it has any psychological factors because of that, and that leads to sexual issues. And you should always gather an information related to where it is coming from. Is it because of from the nerves or from the muscle or from the blood flow or any other characteristic feature or from the, depending on the intensity, we have to find out what is the potential etiology it should have, all these things, and ultimately the psychosexual events which leads because of that. So that is how you should approach a patient with painful sex that is a sexual dyspareunia. So whereas the sexual dysfunction, it is entirely different. It is maybe a psychological factors is a predisposing factor. It could be some other relationship factor or a psychosocial factors. But this painful condition definitely has to be approached with a pain intensity for managing the patient. So it is a clear once conceptualization. The pain condition may have a dramatic impact on how the treatment is approached with the patients. If you treat them for the sexual dysfunction, they will not be getting relieved. You have to treat the pain. That is very important. So the differing approach is particularly very important because it's the pain-driven treatment programs are generally more efficacious for the women with the vulvodynia. So a clinician approach purely should not be for the sexual dysfunction. Then if they do that, that will lead on to a psychosexual causes and its treatment, but the patient will have a continued pain and suffering, which needs to be properly taken care. So in women with pain or a vulvodynia, the treatment should be conceptualized using a multinodal approach, which includes biological, psychological, social, and sexual contributions to that pain. Although the interference with the sexual activity is an important topic to discuss, but it should not be the sole focus. In view, the dyspareunia is seen as an important symptom of a bigger issue for these women. So how is there any golden guideline? So there is no gold standard guideline for evaluation of the chronic genital pain, but we have to assess the severity of the pain, which is very important. The 6 dimensions of the pain should be taken into account when you come across a woman with sexual pain. You have to assess the severity, which will give us an idea how we can treat her. What are the treatment plan that we can have for her? So very important that we have to assess a proper history, both general and sexual, and the local physical examination, a genital examination, and the investigations. So when a couple comes with an initial visit to your clinic with a sexual pain, a very important medical history should be obtained and a physical examination should be performed. The detailed medical history questions documenting the difficulty with intercourse could include when the patient first developed. Is it developed right from the beginning or after some problem? That is very important. Is it painful? The intercourse is painful every time it is attempted or only for some time? Has it been very painful? How, if so? So if intercourse painful with your partner as well as if he is having a pain, that also should be important. Is it a pain in the labia or the vagina or the entire pelvis? They have to point out which area they have the pain. Is it pain during entry? Have you experienced a significant traumatic event in the past, such as rape or the childhood, which is very important for the psychological cause, which may predispose for that? And are you currently being treated for this illness, especially some other disease or disorders, which also could play an important role in the causations? And about the medication she's taking, that is very important. And also any significant emotional event in the life to find out the psychological predisposition for this problem in her life. What steps she has taken to make this intercourse less painful, that also will give us an idea whether it is because of the dry vagina or it could be an improper lubrication or it could be some other reasons of any irritants, which could be a problem which may lead into a diagnosis. So is there any other symptoms she's experiencing? So all these things, a list of questions you should ask a woman when she complains in the initial visit. So that is the dimensions of the pain that you should come to a conclusion, that the physiologic dimension, second sensory, affective dimension, cognitive dimension, behavioral dimension, social, cultural, all these things has to be evaluated depending on the type of the pain. So a detailed pain presentation history is very important. We can rate the severity of the pain scale from 0 to 10, where the 0 is no pain at all and 10 is the worst pain felt. And we should categorize the severity according to the pain scale. And secondly, it is also very relevant to discern how the patient has already tried to alleviate the pain, whether by small changes or home remedies or a changes in the diet or treatment prescribed by other healthcare professionals has to be included in the pain presentation history. The urinary and bowel symptoms has to be assessed because sometimes we know pretty well the urinary infections as well as the bowel infections can also present as a painful sexual problem or in the pain in the genital region. And definitely the other situations which can cause a pain in the area has to be assessed. So the PVD, that is your generalized vulvodynia, is important if the pain is fluctuating or constant. When this fluctuation is happening, whether it is induced by some procedure or some touch or some point has to be very clearly, detailedly, you should inquire with the patient. And secondly, if the pain is initiated by the penetration or by touch, that is also very important to identify the exact type of pain, and thereby you can plan a selective treatment options to correct the problem. So next is the physical evaluation. If the woman's history suggests that she is suffering from a chronic pain, a proper gynecological examination should be performed. As we do a vaginal examination, we have to examine the whole vulva. We have to see the vestibule. We have to see the urethra. You have to see the skin over there. You have to see up to the navel to check whether there is an associated skin infections, which could be a cause for her pain. So a thorough, proper gynecological examination is mandatory, right from the inspection, palpation, pelvic examination, speculum examination, and also to see the cervix as a whole. All these things has to be done meticulously. So this will give us an idea whether it could be an infection or it could be a fissures or it could be an anatomical abnormality or a scarring or any dermatological conditions. So next important test we should do in a next to the gynecological examination is the cotton swab test. We all know the Frederick's criteria, how we have to assess the vulvodynia, where we do the cotton swab test. If everything is normal, if the skin is normal, vagina is normal, still the woman has having a pain, you should find out the point of pain by using the cotton swab test, which is using a moistened tip of cotton or swab to apply uniform amounts of pressure to various areas of the genitals. A typical pattern may involve palpating in the labia majora. You start with the labia majora, labia minora, and also the vaginal introitus, as well as all around the vulva. So that is the picture which shows how we do the cotton swab test. We check each point with the pressure using the moistened cotton tip, which will give us exactly where at the points where the women have the pain. So this Frederick's criteria diagnostic, which is very important to find out a local vestibulitis type, or it could be a generalized type, or it could be a provoked pain. And also you have to see for any vestibular erythema with the various degrees. And definitely this is a very important step to find out the type of vulvodynia, the point at which she has a pain, and how much it is provoked, and what is the pressure point, how much it's a pressure is needed to provoke this pain, which are all very important to plan the treatment proper. So touch or pressure may or may not be prompted, but this may make the pain sometimes worse, especially in the perimenopausal and the postmenopausal women. So next, very important, when you look into after the general examination, gynec examination, and after the touch point, you have to do a proper psychological evaluation, which is also very important after the pain evaluation, to find out exactly how they feel about the pain. So this psychological evaluation, which is mainly important to find out the effect of the pain or the characteristic of pain, is by using some validated questionnaires we can give it to the patients and get the evaluation done, which is done by a pain catastrophic sign scale, pain anxiety symptom scale, vaginal penetration and cognition questionnaire can be given to the patient to assess the severity of the pain. And definitely because of this, how much she is affected, how much the pain has affected her day-to-day life, definitely has to be evaluated to plan her treatment, for which we can give the women for a pain disability index score, a FSFI index scoring, a relationship assessment scoring. These three are very important when it is important when you're treating her to see her improvement and see her improvement in the functioning, and also see how she progresses during the treatment and due to the treatment, her improvement. So these are all some important indexes which you should give it to the patient and get back as she's progressing on the treatment, which will definitely give the healthcare professional a better way to assess her improvement in the treatment. And very importantly, you should not forget to assess the social and the environmental influences, as rightly told by the last speaker, that as lack of sexual education and also the negative stigma about sex and also the genitals and a lot of relationship problems and the negative messages about the sex and genitals, all these things will definitely have a role in causing this type of pain. So that also has to be included when you are approaching a patient with sexual pain. So thorough investigation related to the pain, its effect and its outcome, and the part of its affection in the women's life has to be completely assessed. One important part is the physical therapy evaluation, because we all know the pelvic, PVD or the vaginal penetration disorder usually involves the pelvic floor muscle. So very important, we have to assess the pelvic floor muscle, which plays a very important role in precipitating the PVD as well as the perpetuating, it could be a perpetuating factor. So definite assessment of the pelvic floor muscle by a physical therapist should be a crucial for the diagnosis and the treatment success. So we have to evaluate the pelvic floor muscle, whether it is a hypertonic, and also we should see the gait of the women, the body changes, and also her posture, which also very important to assess the hypertonicity of the pelvic floor muscle. In addition, after doing that, to come to a still more precise diagnosis, we can do a proper visual examination, we can do a biopsy, we can do an ultrasound, we can do a colposcopy, cystoscopy, all these things to find out a wet mount and a culture of vaginal discharge to see for the infection, a serum testing to rule out any specific sexually transmitted disease, and laparoscopy to find out any other PID and endometriosis, a proper bimanual examination, and an electromyelogram to rule out any neurological causes. All these medical diagnostic tests is to be included in this women for the assessment. So in this way, we can differentiate the differential diagnosis of these conditions, which can be ruled out by these investigations as a differential diagnosis. So let me put it as a chart. So these are all the various medical disorders and how much it has an introital pain and a deep pain and a postcoital burning. That has been given a good classification when you look into each of these conditions, how far it is impact. For example, if it is an endometriosis PID, that has an introital pain less, but it has a deep pain, and usually it has a very comorbid with along with vulvodynia. Usually they will have irritable bowel syndrome, which will be associated with a vulvodynia. And if you look into the genital prolapse, there won't be any introital pain, but they will have a deep pain, and there will be a vulvar burning after intercourse. And definitely a vulvodynia, which is a provoked, they will have an introital pain more. And once the penetration is over, they won't have much pain. But they usually, after the intercourse, they will have a postcoital burning, and the burning of a fluid-like feeling, they will have a burning sensation. So these are all some important usual causes. The PID, endometriosis, prolapse, and the vulvodynia has to be very much clearly differentiated by their typical presentation from the clinical symptomatology. That's very important. And if you see the infection, if the vulvovaginal infection, it will have a pain during introital pain penetration as well as during deep sex. And definitely they will have a pain all through the infections. So these are all some classical presentations which you should know, the medical disorder and the presenting, which will give us an idea of how we are going to manage them. So these are all the things that are very important when you are planning for a treatment. So you have to evaluate this important aspects of the vulval pain disorder to plan their treatment proper, to have a proper goal of motivating the women for completely clearing the problem. And also it will be helpful to see how they progress and how they are improving the condition and to plan their treatment proper. So that is a chart to take home a nutshell. When you come across a patient with a sexual pain, a proper medical history with the symptoms accompanying, what is the type of pain, which is an introitus just penetration or deep pain, or whether it is lifelong or acquired or only with few person, or it is with always. All these important questionnaire is important, and a clinical assessment of the pelvis is very important. A Q-tip test is very important, and a vaginal smear and a culture has to be done, ultrasound, to rule out the other causes, like in the pelvic causes, could be an endometriosis, could be a ovarian cyst, or it could be a fibroid, or it could be a PID, and a pelvic map or a pain map to see the pelvic floor improvement, and a definite hormone profile has to be done. And markers for inflammation can also be included in the investigations. And sexual history and the relationship history is very important to have an impact on the negative sexual experiences and sexual expectations, a psychological history about the past and the current depression, and also a coping mechanism, how they cope up. All these things should be there when you come across a woman with a sexual pain. So this is very important when you are planning for the treatment. So the treatment should be a multidisciplinary diagnosis. Assessment of the case history is very important. The pain, the intensity, where it is affected, whether it is a mucous membrane or the pelvic floor, whether the partner related problem or a sexual related problem, or it could be a psychological conditions. With this assessment, with the case history and the assessment and the diagnostic points, you can come to a diagnosis to plan the treatment proper. So with this, I would like to thank Neeraj and the Sexual Health Committee, Foxy, for giving me this opportunity to talk on this nice topic of genital pelvic pain penetration disorder, how to diagnose, how to evaluate the women, and how to plan her treatment proper. Thank you.
Thank you so much, ma'am, for such a detail in such a simple words. And really, I think our viewer definitely benefited from this. So moving to the next part of our scientific session, and to Sunil sir. Sunil sir, are you there?
Yeah. I'm very much there.
Yes.
Is my voice coming loud and clear? Is it okay?
Yes, sir. Definitely,
Okay,
sir.
fine.
Okay, sir. Sir, next and last part to you, management part of this pain penetration disorder. You, sir. Over to you, sir.
First of all, thank you very much. Thank you very much, Dr. Neeraj, for organizing these fantastic programs. Thank you very much, Dr. Shantanu, Dr. Jairani, because of you, my work is so easy. Beautiful lectures by you. Thank you, Apurva, for organizing it so well. And first of all, I'd like to know from all of you who are listening to us, would you now like to know the treatment and management of this pain disorder? If yes, please let me know as I in the comment box. Thank you very much. Thank you very much for being here, because I think though in the pandemic there is very little to do, but still, if you could spend time with us, thank you very much for being here, taking out time. You could have been doing anything else. And I really would like, and we all have been trying to really add value to you. I am Dr. Sunil Jindal, and let me just share with you of how this vaginal pain disorder or sexual disorder became a part of our armamentarium. I'm a reproductive medicine specialist. My wife also does reproductive medicine. About 14 years back, this lady who was a friend of my mother, she came to us in our clinic, and she had come with her daughter who had been married for about 5 years. Daughter was an IT professional, and she got her, and she said that she's not having children. So I've brought her over so that probably she needs IVF. So Anshu examined her, and after examination told the mother that they've never had intercourse. And on further history, this lady had vaginismus. So the mother came to my clinic, and I still remember sitting in front of me, she started crying. And she started crying. She really started howling. And she said something very interesting. I think there is something wrong in my bringing up, because of which I have not been able to bring up my daughter in a proper fashion. That today, this is what has happened. It would have been very simple to do an IVF for a patient like this who has good ovaries, good sperms. But for her to enjoy sex, make it a part of her life, bring in this into the system was more important than anything else. So 14 years back, my wife and me, we sat down to treat these patients. And we actually, in the last couple of years, have had a lot of patients who need treatment. And we designed, after reading, after meeting people, after learning, some new things of what exactly we need to do with patients of vaginismus. So there are two parts of it: dyspareunia, which could be postmenopausal, and of course, vaginismus. So I'd like to simplify it as much as possible for all of us to know exactly what is it and what needs to be done. So I like to share a mind map for this. So I'd like to talk about genitopelvic pain disorder, but particularly I'd like to bring over here a few things which I think are pertinent. And they are, I would like to talk about the diagnosis. I would like to talk about the multidimensional nature. I'd like to talk about the roadblocks which are there. I'd like to talk about the intervention which is needed, the steps of intervention, and each session, it takes about 2 to 3 months to go ahead and actually get over with this problem for these patients. And if we look at it, there would be about 8 sessions which need to be taken for them. And they're all different sessions. So what we need to do, how we need to do, I would individually like to talk about it. So first, my job has been done fantastically by Dr. Shantanu, but there are a few things which need to be understood. So the difficulties with vaginal penetration during intercourse is something which they would complain about. But more than that, when you talk to these patients, you realize that there is a great fear, anxiety associated with vaginal penetration. And more than that, just like an involuntary reflex, the muscles of the pelvis just tighten together. So it has a great psychological overlay. There is fear, there is anxiety, and they just would not allow any attempt. Let me also talk about something else which is important is, most of these patients don't want to come to you. In fact, a lot of our patients, when they come to us, they say, "Bas bachcha de dijiye, baki ki chinta mat kariye." Why? Because the fear of pain is much bigger than the pleasure of sex. Because sex in itself has a fear for them. So it's a very interesting thing that when a man comes to you with an erectile dysfunction, he rushes to you, he comes to you again and again because he wants to get over with the erectile dysfunction. But a woman with vaginismus doesn't want to come to you because she just doesn't want sex. So the diagnosis of this is very, very important and pertinent. Now, this is a multi-dimensional treatment. Multi-dimensional treatment because it doesn't involve the gynecologist only. It involves a psychologist, a psychotherapist, a pelvic physiotherapist, and of course, the clinician. So vaginal penetration, pain, anxiety, muscle tightness is also associated with the couple dynamics and sexual satisfaction. And apart from that, what you need to do is the pain management, the desensitization, the cognitive brain restructuring, how they look at something and how it appears to them, pelvic floor exercises, sensate focus, and mindfulness. I mean, it is something which involves a lot of time and a lot of understanding. Now, let's talk about some roadblocks which these patients have. So these patients have a few roadblocks. First of all is, it's a taboo. Sex is a taboo. Dysfunction is not regarded as a disorder at all. So nobody talks about it. Self-stigmatization also leads to a lot of shame and guilt in them. So they don't open up in front of you. I still remember a couple of patients They just won't talk about it. And the only thing they would say is, I just want a baby. And somehow deep down, they feel that guilt that they're not able to give pleasure to their husband and that there is something phenomenally wrong with them. And we as healthcare professionals, Dr. Pankaj actually told a beautiful story in the beginning. We as healthcare professionals do not standardly ask patients. And more than that, we are not trained for that. And just like culturally and in society, we do not consider sex as eating food or taking a bath or brushing our teeth, which is so natural. It is just another natural part of our existence. Now, what is the intervention which would be needed? So I'd like to talk about the intervention which would be needed. So the intervention which would be needed would be, session one would be psychoeducation. Session two will again be psychoeducation with a structuring which I'll talk to you about, and non-judgmental awareness. Session three would be where you would expose them to relaxation exercises, pelvic floor relaxation exercises, attention focusing on pain management, and gradually the vaginal exposure to the finger. Number four would be the body exposure and genital self-exploration. 5 and 6 again would be exposure with dilatation and building a sexual desire and arousal. See, the most important thing is for them to develop the desire, the arousal, which doesn't exist because of fear. And then finally, sexual intercourse, plan for the future to prevent relapse, and a booster session. So this is the way we normally would go ahead with the intervention. I'll go step by step to make it a bit clearer and very simple. So first of all, psychoeducation. See, we need to understand a few things that when the person comes to us the first time, they need to have an overview of the program, of what is needed for them. What are the things which we're going to do? And what are the expectations which we have from the patient? They also need to have goals, because unless and until they have goals and homework, this job won't be done, because they fear it. Very simple. Even if a child goes to school and he does not have a test on so and so date, he doesn't have to finish his homework, that chapter would never be done. So goals is most important. The next is the strengthening of motivation. And the third is, apart from support from the clinician, the psychotherapist, you need support from the husband as well. So it has to be a support where both of them together plan, make goals, and understand of how to go about doing work for this. So the session 2 is the restructuring session. So now what happens in the restructuring session? I'll very simply like to explain. See, these participants are giving an opportunity to find out their own fear avoidance emotion. They have to find their cognition, emotion, physical reaction, behavior. Like for example, a woman may be becoming angry the moment sex comes up. A woman may become anxious. She may go into a shell. She may talk about how much she dislikes somebody. But all these emotions which she gets, the deeper basis of that is not the emotion. The deeper basis is wanting to avoid the fear and the pain. So this is something which needs to be restructured. And in the restructuring, the first step is for the participant to understand the negative condition and distorted belief which that person has for sexual intercourse, genital pain, sexuality in general, and learn how this influences their emotion and their behavior. And in the second step, after understanding this, they need to restructure and replace it with encouraging ones. So they need to understand, first of all, that sex is good, sex is normal, sex is something because of which this world exists. And more importantly, the belief they have about sex and the conversation needs to be changed. And apart from that, they also need a non-judgmental awareness. I'll give you an example for that. Now, supposing today I meet somebody and I think that man is a liar. So whatever he says to me, I'm wearing glasses. And because of those glasses, whatever he says, I'm going to think in that fashion. I will not be able to make a connection with that human being. So I'll be wearing sunglasses. So till the time I remove that judgment, those sunglasses, I will not be in a position to make a connection with him or a conversation in which I'm not always thinking. This is a very important part of the restructuring of these patients. Now let's come to the third, and the third portion is the relaxation. So a lot of relaxation exercises are needed, and these relaxation and breathing exercises be pranayama. You also have a lot of yoga postures where there is pelvic relaxation, which needs to be done by these patients. And apart from that, what they need to be doing is to also, they need to be introduced to something, the relationship between the pain and the anxiety which they have. And because of the pain and anxiety, something which suffers is sexual arousal and muscle tense. So they need to realize what is happening. And they need to realize it on their own. I mean, you can't coach anybody till they understand these things on their own. Now, next comes body exposure. See, I'll give you an example for it. Now, supposing I stand in front of the mirror and tell myself, I am amazing. I become amazing. A lot of women always want to have sex in the dark because they're not comfortable with their body and the arousal is low. In patients with vaginismus, these women have this issue. They are not comfortable with the lower part of their body. In fact, a lot of them have really never seen it in the mirror even. So one thing which is very important is for them to become comfortable with their body, for them to explore their body, and for them to know exactly about their genitalia and being comfortable with them. So body exposure and self-exploration is very important. And this first includes the therapist to explain to them through an illustration and drawing of how the pelvic floor is. The second thing is that they need to explore their vagina in front of a mirror. And they need to be comfortable with it. And they have to be non-judgmental and mindful of any negative cognition or emotion. I mean, they have to realize it and be non-judgmental. And this can be complemented by shorter body exposure exercises where they expose themselves and become comfortable with their own body. This is a very important step. Are you there with me? If you're there with me, I would continue. I would continue because further on what needs to be done is very important too. So let's come to the sensate focus. So we have to understand that session 3, 5, 6, and 7 is also vaginal exploration with the finger and a dilator. But since in session 4, something important is there, which we need to understand. And this is that the aim over here is to promote physical intimacy, reduce stress, pressure, anxiety, by emphasizing that the experience of sensual pleasure between the couple. So the husband and the wife or the partner, they need to be comfortable with each other. They need not have intercourse, touch the genitalia, but they need to feel each other. It may be in the form of massages or touching each other, of starting to be comfortable with the body of each other, which would be session 4. Now, I would talk about the session 6. Now, the session 6 is when you build up the sexual desire of these people. Like one of the goals would be to increase the sexual desire and arousal, as both have to influence ultimately penetration and pain, and information of self-stimulation and masturbation techniques need to be given to them. Now, apart from that, something which is the doing part, which is about 4 sessions. By 4 sessions, I don't mean during the sessions. By sessions means after explaining them, they're doing it for the whole week. So they have to put in about 1.5 months into this. And they really have to do their homework. So first is the gradual vaginal exposure is combined with pelvic floor exercises. So they need to do yoga and need to expose their vagina to themselves. All these things they need to be explained that they need to do. First, an insertion of 1 or 2 fingers is done by the woman. After that, 1 or 2 fingers by the partner, where the woman guides the fingers of how much she wants them to be. I mean, she doesn't need to be hurt at all. Third is self-insertion of dilators of different sizes, with the largest dilator being similar to the size of the penis. Then, insertion of the dilator of increasing sizes by the partner, guided by the woman. The man doesn't have to poke it in. The man only needs to do what the woman allows. Then they have been encouraged to keep the dilator inside the vagina for longer period of time. It could be even up to an hour, and to get used to feeling and being habituated to it. And of course, the participants are advised to use larger dilators if they are comfortable with repeated insertions. Now, this becomes something which the person needs to do very slowly, doesn't need to be poked. Fear doesn't have to be. The realization that it is normal, the realization that the emotions and bad thoughts are not associated with sex, along with that, realizing that it is not painful, is what needs to be done. Then we come to the session 7. In the session 7, it involves for the man and the woman touching of the vagina with the erect penis without insertion. Then insertion of the penis without moving. And finally, moving the erect penis within the vagina. This finally would be when the sexual intercourse would be there. And of course, once this is done, they need to be given the plan for the future. But the most important thing of this whole system is following the system with goals by the couple. This is an area where your player doesn't want to play because he fears playing the game. It is not that he loves playing the game. He would love ultimately playing the game, but he fears playing the game. So after this, I have a small presentation, though it's already, I'll just talk about a few drugs about dyspareunia, if the time permits. And otherwise, I've covered vaginismus per se. And if the time permits, I could just talk about, Dr. Neeraj had been telling me about what drugs could you use, what medicines can you use. So I'll just touch that topic quickly. I think that is very important.
Yes, sir.
So I'll just touch this very quickly because it needs to be touched quickly. First of all, Dr. Jairani has really explained this beautifully. I'll just talk about prevention. Now, for prevention of dyspareunia, you can do nothing about sexual abuse and trauma. But there are a few things you can do. You need to decrease yeast infection, avoid vaginal infections, wear cotton clothing, have good hygiene, change undergarments, avoid bladder infections, wipe front to back during toilet, urinate after sexual intercourse, avoid sexually transmitted diseases, prevent vaginal dryness by using lubricants. If you have endometriosis, get it treated, or have intercourse which is not deep and during the mid half of the cycle. This is prevention. Hormonal changes, we understand that estrogen is needed. And estrogen is not only needed for the vaginal lubrication, it is also needed for the arousability. Androgens, quite contrary to the thought of what it was earlier, is the sex hormone for men as well as for women. And the balance of the neurotransmitters between the excitatory and the inhibitory signals is on the basis of androgen. So a decline with aging is related rather than by menopause related, and by age it decreases. So Dr. Jairani has spoken about the psychosocial therapies, but these are the therapies which need to be given. There are a couple of things which are included, which is the basic counseling, the physiotherapy, the psychosexual intervention. Now, basic sexual counseling is most important, as I had spoken to you about. We need to improve the intimacy between the couple. The fear needs to be out. And for that, we need to educate patients. They need to enhance their stimulation. And they could use some distraction techniques, which could make them relaxed and eliminate anxiety. Body awareness is needed. Cognitive therapy I've spoken about. Behavioral therapy I've spoken about. And psychodynamic therapy also is needed in these patients. Now, when it comes to vaginal moisturizers and lubricants, they become a very big area in dyspareunia, and they are recommended as the first line of treatment in mild to moderate vaginal dryness, where local estrogens are contraindicated. So the moisturizers could be, which are able to retain moisture and stay for some day. They could lead to hydration and physiological vaginal secretions by mimicking. And the lubricants, on the other hand, are specifically designed to reduce friction during coitus and making it more comfortable. So these are oil-based, glycerine-based, silicone-based. Most commonly used lubricants in our country at times is coconut oil. So if they are water-based, they're washed off very quickly. They're very good for sensitive skins, easy to wash away. There can be some, and they're proprietary available in the market, which are water-based and pH balanced. They could come with fragrance. A lot of companies produce these water-based lubricants. They can be silicone-based. They feel silky. They last longer. They do not dry up, and they can be used with condoms. So a lot of these are available. The names, of course, Astroglide, Slick and Slide, gun oil lubricant. I mean, there are a lot of them which are available in the market. Now, glycerine containing, we all know, and the most commonly used is KY jelly. Water-based, sugar-free, won't stick. But because they contain a little bit of glycerine, they can lead to yeast infections, which we need to understand. Estrogen therapy is something we all know about, which needs to be given, can be given. But something for us to understand, in this whole scheme, the sexual desire, sexual arousal, orgasmic disorder, vaginismus, dyspareunia, they're all together. And in fact, they are interlinked to each other. Now, local estrogen therapy is available. More than tablets, local estrogen as natural estrogens, estriol, promesterine are used, and they typically are very, very helpful in the perimenopausal time. Nitrica gels, which are L-arginine gels, are also available. They're supposed to improve the vasculature, make it more lubricant, prevent dryness, and these need to be applied once or twice daily. In a lot of patients, selective estrogen receptor modulators, which are synthetic non-steroidal agents, can be used, and ospemifene 60 milligram daily orally is proposed to those women who are not eligible for vaginal estrogen therapy. It exerts a positive effect on the vaginal endothelium and minimal effect on endometrial tissue. Androgens are used for desire, and today, in fact, androgen gel, testosterone gel, is freely available in our country to be used, especially where there's hypoactive sexual disorder. And even because of hypoactive, it leads to a loss of libido and it leads to dryness in the vagina. So these gels can be used by application on the skin. And once they are used, and in fact, there have been the maximum number of studies on this, on the testosterone gels, and they very well can be used in women who have hypoactive sexual disorder, but also in women who have vaginal dryness and low arousal. DHEA orally has not been very effective. A few studies have come up where vaginally it has been used in menopausal women for dyspareunia. And of course, there are a few things which we see nowadays, which means laser, which we have. What it does is it leads to local stimulation. It's aimed at increasing production of collagen in order to improve functionality, lubrication of the vagina. And of course, two pilot studies were done where G spot was injected, and this G shot, what is known as, was used using the PRP. Though in fact, PRP today is injected anywhere and everywhere, but a lot of studies have come up where the vaginal health index score has been expressed in terms of vaginal dryness and dyspareunia after 6 months of treatment in a better fashion. So the future probably would be PRP, but we still have to see. And well, the first line approach would be education and empowerment involvement. The second line could be giving them lubricants. Laser therapy has been given, pelvic physiotherapy can be given, dilators can be used, sex therapy can be given. If this does not happen and moderate cases are there, non-hormonal is needed because you can't give hormones. You may need to give a few local therapies. You can give these patients local estrogens if they tolerate, give them transdermal testosterone. And of course, it's a combined treatment of psychotherapists, pelvic physiotherapists, and of course, the gynecologist. So in the end, I know it has been exhaustive. I've tried to make this topic as simplified as possible. Oh my God, this is gone. As simplified as possible. But if you ask me very honestly, something which is important, Dr. Neeraj, thank you very much for forcing me to make this topic as interesting as I possibly could. Thank you, the audience, for being here.
Thank you, sir, for this wonderful, what to say about this. You make it so simplified, so easy to everyone. I think even laymen can understand the things and the topics which easy way you describe it, sir. Thank you so much, sir. Thank you so much. Neeraj, sir, you have to unmute yourself, please. Yeah, ma'am.
So I have one question.
Yes, please.
So, Sunil sir, that was a fantastic deliberation about the vaginismus treatment, and you have made it very nicely and very, very interestingly. You have made all the sessions of what the treatment that you used to give. I want to add on one factor. You haven't talked about the male partner, which is also very important
Oh, yes.
when
Oh,
you come
yes.
across women with vaginismus, because 60% of the male, when they have a vaginismus partner, they will go for an erectile dysfunctions. We should look into the male component, very important when you come across. It's not only the vaginismus you treat, because they would have lost their erection because of the prolonged failure of proper sexual intercourse. And definitely that part has to be addressed when you are treating as a couple for a proper sexual intercourse.
In fact, in the first 2 sessions, when you talk to them about it, this comes out with from both of them, especially the male. And it's a very interesting thing that you're right, 60% of the men have secondary erectile dysfunction. And the reason is very simple. I mean, because these loving men who don't get sex are not rapists. So that is the reason they have secondary erectile dysfunction. And yes, of course, we always ask them to come as a couple, which is most important. And it's a very nice point which you brought out here. Because of my wanting to rush through the whole system, I could not go into details, but this is something which the audience should understand. Thank you very much.
Purva, any attendee question is there?
Yes, sir. There are few questions. I think, sir, most of the questions are actually covered by our faculties. I think this is also being discussed. Ma'am, just I wanted to ask this question to you, Jarani ma'am. What is the role of IFM chair in vaginismus?
Yes, that can be used as it is. There are a lot of, it's a latest one, which can be used for the vaginismus. But generally, they use even a vortex injection, which can be used in part with this, because definitely this is a very costly one. So it's simple, as sir rightly said, that they can use even a vaginal laser. They can use even a, a platelet PRP, and all those things are much more better than this. Less, less cost, very easy procedure, and very good improvement will be there for this treatment instead of going for that.
Thank you so
And,
much.
Apurva, there is another question. Someone want to know about the names of lubricants and the vibrators.
Yes, sir. Yes, sir.
Sunil bhai, can you tell us?
Yes,
Name of
please.
lubricants.
Can you repeat it,
Name of
please?
lubricants.
Sir, what is the different brands name which is available or the lubricants? You are talking, yes, sir. You showed the slides about the lubricants and creams which are used. What are the various lubricants available in Indian market? Basically concerned about the Indian markets. What brands are available?
See, this Indian market is full of lubricants. Let me be honest with you. And the most common lubricant used by the Indian public is coconut oil.
Coconut oil.
And in fact, a lot of them, let me be honest with you, and I'll just share with you our experiences. A lot of them would normally talk about something also. They would always say that I use badam ka tel. So 2 lubricants which are most commonly used are these. KY jelly is very commonly and very cheaply available, which is a water-based lubricant. Durex has a lot of lubricants available in the market, which are pH controlled, and a lot of them also have flavors, and a few of them also have, I would say, perfume. Smells. There are also a lot of them available like oil of gun, silicone oils, lots of them are available. But most of my patients, I tell them to use something like KY jelly, which is very, very comfortable with them. A lot of them also purchase the ones which are made by Durex. They come produced in China. A lot of them come over from there, and they're all available in the market. There's another one which is available, which is very popular in our area, which is Blossom. So I don't know, they buy a lot of it name as Blossom.
I think Indus make one pelvic K gel that is very important. I mean, that is, I think Indus, if my memory is right, it is very much commonly available. You can just have it in the pharmacy, because Durex, you have to get it from the Amazon. It's not available, but now pharmacies, they too have a Durex. You can get it in Amazon also. Pelvic K gel.
In fact, it's very interesting.
V-Moist, it's also that is there.
We don't realize, because we're not business people. of what a major market this could be.
Yes.
Really, what a major market this could be. I mean, gels, lubricants,
Sir,
moisturize.
even fragrance. I think
They are
fragrance
quite,
does
quite
have some
costly.
role.
What a major market. Like, it's a very, very big market, really.
And
Uh,
there's another
Sir, one
question.
more question.
Yeah, Purva. Go ahead.
Sir, one question to Shantanu, sir. Sir, what is the role of, actually, what is Bartholinitis and dyspareunia? Sir, you have to unmute yourself, Shantanu, sir. Shantanu, sir.
Bartholinitis is, as the name suggests, inflammation of the Bartholin's glands. And
Yes,
if there is active infection and inflammation, it might lead to dyspareunia. Sometimes it leads to a Bartholin cyst or an abscess, and relevant management has to be done. It will only be temporary till the condition lasts, and once you treat the condition, I guess it should treat the relevant pain factor in the intercourse, during intercourse as well.
Sir, one question is actually, I think 1 year back, one patient come to my OPD, and she was a tech lady, tech lady already Googled and everything. So she has a Bartholin cyst, okay, and she wants and there's a large, actually 4 centimeter Bartholin cyst is there unilaterally, and she wants the medical treatment. What was her concern that if you remove that Bartholin gland, so there will be no lubricant will be present during the intercourse, and actually it caused the dyspareunia to her. Probably she go through some, some Google and thing, and the Bartholin glands is usually provided as a lubricant, and she has that. So what's is you in your practice, do you have this type of patient that after removing this Bartholin gland, they complaining of dyspareunia? Is it true?
No, not really, because the Bartholin gland contribute very little, if at all, to the lubricant function. And it is usually the vaginal sweating, what is described as vaginal sweating, the secretions that come from the vaginal mucosa, that cause the lubricant action. There are a lot of glands on the skin at the mucocutaneous junction. The vaginal mucosa itself is free of glands, and this sweating that happens is just the seepage of fluid that happens because of the hyperemia that happens with sexual stimulation. So I guess you got to explain to the patient that Bartholin cyst is of course not going to cause any pain, because it will cause some physical obstruction, if at all. Yeah, but it will not give rise to pain as such. Inflammation, infection will give rise to pain, which will be temporary and which needs to be tackled in whatever way is deemed fit for that particular patient.
For the sexual lubrication, Bartholin's role is very less. The glands, they are the very important one that has the main lubrication effect during the orgasm. So it does, Bartholin's has a very little role.
Same applies to cervix. A lot of people believe, even gynecologists believe, that cervical secretions happen to contribute a lot to coital lubrication, which is not a fact. A lot of couples will not allow adequate time for foreplay. Many of them will not know that something such as foreplay needs to happen, and they would have actually learned their ropes from the net or seeing some pornographic movies, Bollywood and all those things, and they will try and compare their own sexual lives with those of those porn stars, and then they will be miserably unhappy.
It's
very true, sir.
It's very true, Dr. Shantanu, what you have said. I mean, the पैमाना ऐसा बन गया है pornographic videos देख के लोगों का, that most of them are depressed, and the women become extremely demanding. Women become extremely demanding, and it becomes a very funny situation where I got this patient recently, and he had just been married, and this was his second marriage. So his young wife came with him and said, there is a very big problem with this man. So I asked him, what's the problem? He said, no, there is no problem with me. I'm coming because she has insisted. So I asked him that, well, what's the problem? So she said, he doesn't last. So I asked, how much time do you normally take to discharge or to ejaculate? So he said, between 5 to 7 minutes. So I told that, well, I told the woman that, well, 5 to 7 minutes is normal. And I think you have a reasonably good husband. I think you should be happy about it. So she looked at me and said, अजीब बात कर रहे हैं आप, ऐसे कैसे हो सकता है? अब now
She has changed her husband. Now she wants to change the doctor as well.
Yes, because the movies have given her a great idea that he has to last for 20 minutes, 30 minutes, the length of the movie she has seen. So it is so unfortunate that this has become the training ground. And unfortunately, another thing which on a very serious note, there is no sex education in our schools. There is no sex education of children and college boys. There is no sex education of girls. They have all wrong ideas based on what the mobile phone gives to them. And this country, for all the problems that is happening sexually, is to be blamed not on the pornography, but the fact that we are not comfortable as human beings to discuss sex and talk about sex education.
Correct.
Dr. Neeraj, it's fantastic that you are doing a great job, but I think it should go into the schools by all of us.
But there are lots of issues in the school program, so we will try it. But let's hope we can do that. And
but I would like to share. So, but I would like to share the WHO in Jharkhand. They have a very great work with the WHO doing the comprehensive sexuality education in Jharkhand, and they have found out a very great improvement and empowerment in the school children, and they have got a very good, improvement in the especially Jharkhand. We
Apurva is from Jharkhand.
Sir, ma'am, I am from Jharkhand actually, and
Yeah.
I am
Jharkhand is
why
pilot
WHO?
state for the WHO for the
Yes, sir. And
comprehensive.
why this happened? Why this happened? I am telling you, ma'am. I have seen the patient. I have seen the patient. The 7 and class 8 ladies are coming. Matlab, they are hardly 13 or 14 years of age, and they came for the abortions and everything. It is so much. What we are actually I think so. We are in a very wrong state of mind. If these type of things are encountered only in the cities. No, the actually is even in the villages and even where the education is less, whether even in the tribes and other places where we actually think no, the things are better, but actually it's not better. So it was Jharkhand government are actually using that, but unfortunately they have I think 3 or 4 years back they started this type of things, and after that whole lockdown, all the schools are closed and everything is closed. So this is they have started it, and but unfortunately it was closed right now.
So I want to know.
Even interestingly, in Pakistan, what we think is a very conservative, very thing, they are doing a lot of CSE very importantly. Only India has to have a lot of improvement, and we all should work for it.
Sunil bhai, I want to know one thing.
Yes, sir. Neeraj, sir. Yes, sir.
How long we can use estrogen cream safely for this dyspareunia?
I beg your pardon, sir?
How long we can use this estrogen cream safely? Since how long duration we can use this?
Estrogen cream, no?
1 year.
Estrogen cream per se is normally not given for over a very long period of time, though it is very safe otherwise. I mean, it's not an unsafe thing because it's a local absorption, but normally about 6 months or so is what we normally give to our patients.
What's
And
your
the mantra is that if you don't use it, you lose it. So by regular sexual intercourse improves the health of the mucosa as well as the blood supply. And the creams are only to establish a regular pattern of sexual intercourse. And the couple needs to be explained that if they may believe that beyond a certain age sexual intercourse is unimportant, unnecessary, or even sinful, which is not the case.
And what about testosterone, Dr. Sunil sir?
It's very interesting. We need to tell the patients that testosterone gel needs to be put on the skin. It doesn't have to be put in the vagina. Very important. In fact, a lot of hypogonadotrophic hypogonadism, which I treat, when I tell them you need to take testosterone gel, I always give them in writing it is not to be applied on your penis. Believe me.
How long it is to be used? Testosterone gel, how long we can use?
Testosterone gel till now is advised maximum 6 months. Okay. Testosterone gel. And androtas is what comes from Intas. It's very freely available. So it's about 12.5 milligrams is one. Once when you press it, what you get is about 12.5. So that is what needs to be used.
No, so how is your experience regarding dyspareunia and testosterone? Have you used this much
No,
frequently? Or
I have not actually used it in dyspareunia. I've used it in hypoactive sexual disorder. So
Dr.
that's what
Jairani, have you any experience?
Yeah, we always use for hypoactive sexual desire disorder the testosterone gel or the patches which we use, because generally in a younger age group, in a perimenopausal age group, when there is a hypoactive desire disorder, the testosterone gel has a very good improvement. And for an atrophic vaginitis in a postmenopausal women, for them we use, especially when they have a urinary symptoms, a genitourinary symptoms, they have a cystitis, recurrent urinary infection, this estrogen cream can be used not in the vagina, it can be used in the thighs, because the absorption is the same and the effect is going to be the same. You need not apply over the vagina or over the vagina, because the absorption will be very less. If you use in the thighs, that will have a very good improvement. You can use till her pain and her discomfort gets, unless otherwise she has any contraindication, and she needs to have a proper follow-up of a gynec examination by our pap smear and other testing to rule out any other changes in the cellular histology.
What are the
Can
contraindications?
any one of the esteemed faculty please share their experience regarding testosterone used in a postmenopausal women to improve libido?
Yes.
And what are the contraindications for testosterone?
Generally, any malignancy, any pre-malignant condition, it is not advised. Any hormones for that matter. If she has a previous family history of any genital, problem, that genital pre-malignant condition or a malignancy, it's contraindicated. And of course, any virilizing tumor, any adrenal problem also, we are not supposed to use. If there is no other contraindications, we can use it safely. Because we all know, even in a young women, the testosterone is higher because that is getting converted to your estrone, your estradiol. Estradiol is converted from the testosterone. So we have testosterone even in the ovaries, but it is a component of the testosterone which gets converted to have an effect on the estrogen. So definitely testosterone is there in the women also. So it's not that contraindicated even for a younger women. But of course, if there is any specific contraindication for estrogen, that applies and hold good for testosterone also.
Is there any other question, Apurva?
No, sir, all the questions were answered. Sir, we can do one thing. From each faculty, we are asking about their experience, about their some unique case, which you want to share with us. Is it starting from Shantanu, sir?
Rather than a clinical case, I'll share my experience regarding sexual and sexuality education. That point was so pertinently brought up by Madam. The same media that helps to spread canards and misinformation and disinformation about sex and sexuality can be harnessed to spread the correct information. And I have an experience of starting a YouTube channel and some 35-40 short clips, nothing more than 3 minutes at a time. And I speak to the camera. There are no visuals, nothing. It's plain, simple, scientific talk. And these clips, they have received an immense popularity. And we have more than 1 million hits to this particular, total hits to these video clips. And they're widely shared on the net. So I guess this should happen in each of the local language and we all should do it. It's a very simple thing. You just record some 2 or 3 minutes, important points about sex and sexuality so that, age appropriate, correct and scientific information is dissipated through the same media that is creating problems.
Ma'am, Jairani ma'am, any special cases or anything from your experience about today's topic? That is the penetration.
Share you 2 things. We have conducted one study because my center, though I'm a practicing IVF specialist at reproductive medicine, just like sir and madam, but we have a sexual medicine clinic along with my husband, Dr. Kamraj. So if you see our incidence of vaginismus or a penetration disorder conditions and unconsummated marriage, it is around 22, though we say 5 to 6% is an unconsummation marriage in the general population. If you look into our practice, we come across up to 22 to 26%. We conducted one study where we have around 430 cases of unconsummated marriage. So unconsummated marriage, if you look into it, you have a very, very, very highest number of this unconsummation happens in an IT sectors. Though we think that an uneducated people may know less about sex, but these people are the one who are more sufferers. More of these people getting affected with unconsummation, especially vaginismus and erectile dysfunctions. Both together, they come. So I have a lot of patients who come for IVF, who come for treatment for infertility. But when we correct the sexual problem, they get the pregnancy in the bedroom, not in the laboratory. So that's what we always say. Always a natural way sex is very important to get both the couple's happiness as well as the family's happiness. That's what important. And very interestingly, nowadays we come across a lot of patients coming with, especially from the IT sectors, who have a unconsummation marriage is very common, with both the couples having a lot of stress and increasing divorces, a lot of marital conflicts, relationship disorders, and a lot of psychological impacts, and even very great marital relationship problems, all because of unconsummated marriage. And I'm very sorry to tell you, many a times they fail. I think sir will agree with me. They come as a couple, but they were very reluctant for the treatment. And even if you insist them to go for a proper therapy, as sir said about the sensate focus therapy, the erectile dysfunction correction, they can have a beautiful happiness. They never get correct. They want always fertility treatment as the priority. So that type of an attitude should change among the couples. That is a very important. And consummation of marriage should be a very important step in all the sexual dysfunctions, especially in the younger group.
Thank you so much, ma'am.
It's been so beautifully placed by you, Dr. Jairani and Dr. Shantanu. But all these couples who come, it's been a personal experience. If man doesn't have an erection, he can't sleep at night. And if the woman has vaginismus and she has to go next day to a doctor, she can't sleep at night. So the story is different. The man can't sleep at night because he wants the erection at all costs. And the woman can't sleep at night because she at any cost would not be able to tolerate intercourse. So it's very difficult to convince these patients who come for fertility treatment and have unconsummated marriages because of the woman to go ahead and take therapy. They would do anything and everything to avoid therapy. One. So it's a very tough job. It's a very difficult job. One. Number two, unconsummated marriages because of men I have seen a lot of them as well. And my realization is, I still remember, I cannot forget, about 10 years back, I had gone to a conference. It was an andrology conference. And over there, we were discussing male fertility. So it came to unconsummated marriage. So there were few people who had come from the United States. And when it came to unconsummated marriage, a couple of them were quite surprised that they had rarely seen an unconsummated marriage. And over here, we see unconsummated marriages, vaginismus, so commonly that I think, just like all of us believe that sex education at the grassroots in school is something which is the true treatment of this problem. And the problem is people. I remember about 10 years back, I'm just sharing with you, 10 years back, Anshu and me, we made a small program of sex education, and we contacted in our city about 10 schools that we would like to come over and take a 2-hour session with children. In the girls' school, Anshu would go, and the boys' school, I would go. Can you imagine, out of 10 schools we contacted, 8 refused. They refused. And they refused because of one simple thing. Whatever you are saying is very good, but the children, parents, they're going to come and create a ruckus. So even the parents are so bothered कि हमारे बच्चे से सेक्स की बात कर रहे हो आप, या हमने पढ़ने को भेजा और आप सेक्स की बात करते हो. This whole cultural system is a very, very difficult thing to do. Very difficult.
But that is 10 years back, sir. Nowadays,
Yeah.
all happier in their hands, sir. Everything is in
Yeah.
their hands. So 10
Yes.
years back, different. Now, no teacher, no one will ask us because everything is there in their hands. That's what.
Ma'am, is still because 2 years back.
That is why it is still more important for us right now to guide them in the right way. That's very important.
That's very important.
We have to dilute it with the other subject of health and then give it.
Yeah.
There is only way.
The CSE, the comprehensive sexuality education itself, it's very clear in a syllabus. They have given a beautiful syllabus. If you start from the 5th standard, that is the 6 years of age, that is very beautifully they start with that comprehensive sexuality education, beautifully given by WHO. If you follow that, I think we can bring down all these rapes, all these sexual abuses and sexual discriminations and all the gender bias. Everything can go off from our society. Definitely we can reduce that myths about that if you really implement the CSE right from the 6th age up to that level. They've given beautifully, sir.
Only problem is the word sex. If you give health education, then it's okay.
No.
Problem is the word sex.
Sex.
You can't.
No, sir. That's what.
The majority time it happens.
But the schools and parents are now more welcoming, and so many times I've experienced that once you finish your presentation in the staff room, the teachers will tell you, "Sir, you should have been in our school when we were school kids."
So 2 years back, when I was associated with the Adolescent Health Committee, I just wanted to have a, menstrual, in the International Menstrual Hygiene Day, I just contacted, 10, 12 schools in my district. Even they refuses with that. About the menstrual health, forget about the sexual health. So it is really, we should come up with this type of thing so that it's palatable in our society.
Lots of problems are there. Not easy thing to. We can talk, but on ground level, it's very difficult.
We should do it. As rightly said by Dr. Santanu, we should take in our regional languages about all these myths and misconceptions and all about the, that bias and all the abnormal thinking about sex education should be changed. We should do it.
Dr. Neeraj, I have a suggestion through this Foxy Sexual Medicine Committee. You can start a YouTube channel. It is for free, and ask all the members across the country to contribute content in their own language.
Fantastic.
Because a lot of content in English is available, but yeah, and I'll share all the videos that I have done. I'll just send them over to you. You can just let them be there, or you can share the link to each of these channels so that they automatically get and follow that particular channel as well.
Live is messaging Apurva, so finally give word of thanks.
Yes.
Thank you, Neeraj. Thank you. Thank you, Apurva. Yeah, we must thank you.
Before that, sir, I think vote of thanks is still pending. Sir, Neeraj sir, with your permission, so do I start with vote of thanks? Okay.
Yes.
So thank you so much. First of all, the Foxy office bearer, our visionary president, Dr. Alpesh Gandhi sir, our vice president in charge, Ragini Agarwal ma'am, and our secretary general, Dr. Jaideep Tang sir, and definitely last but not the least, the man behind all this program, our chairperson, Dr. Neeraj Jadhav sir. And I really thanks to ICOG chairperson and Dr. Mandakini Megh ma'am, and the secretary, Dr. Parag Viniwale sir, and definitely the faculties for today, Santanu sir, Jairani ma'am, and definitely, and of course, Sunil sir. Thank you for all of you for joining us and giving us the time. And last but not the least, our chief guest for today, one and only great academician, Dr. Pankaj sir, and our supporting team, Lai. Thank you so much for the technical support, all the supporting team in task for giving us this platform and to organize this. Thank you so much. Thank you so much to all of you and to all the viewers and to all those who participate and give us the questions. Thank
We
you.
will send the
Thank you so much.
certificate. Yeah, we will send the certificate in mail. So for the one ICOG credit point certificate is there, we will send all the delegates by mail.
Thank you.
Thank you. Thank you so much.
Like you can now be offline.
Can we be offline,
Thank you,
please?
everyone. Thank you.